the patterns of injury we see in perinatal brain injury. I'm just going to focus today on the preterm. And as you all know, preterm birth is a huge problem. The United States, despite being one of the most economically advantaged countries in the world, ranks number 6 in the rate of preterm births. This is data is a little bit dated from 2010, but even though the decade has passed, we really haven't probably changed much. And if you look at the other countries that we rank amongst, it is fairly embarrassing. Across the United States, both Ohio and Maryland have difficulties with high rates of preterm birth, and that extends across the South. It's interesting because when we look at trials for interventions, we need to think about the regional differences of the populations we see. I think that may have a very significant impact on trying to find interventions, especially when we look at the challenging problems like posthemorrhagic hydrocephalus. And just to emphasize again that preterm birth is the most common cause of cerebral palsy. Unfortunately, we do have a lot of cerebral palsy related to abusive head trauma, but preterm birth still remains a huge problem, with about 10% of our babies in the US born preterm, and that increases up to 15% when we look at areas like inner city Cleveland or inner city Baltimore. As you all know, there's significant chronic deficits from preterm birth, and this is the population I primarily focus on in my clinical practice. Well, only about 5 to 7% of the very preterm babies will end up with cerebral palsy. Approximately 40% will end up with developmental coordination disorder, and this really impacts their progress in school. Many will also have epilepsy. Fortunately, it can often be controlled. And then again, a significant fraction will have cognitive and behavioral problems. And we all know that the injury is worse as their birth age decreases. And the deficits tend to occur in combination. For example, if we look at our kids with cerebral palsy, we see epilepsy in about a quarter of those with spastic diplegia, but that really increases dramatically when we get into the kid and take care of the kids with GMFCS5, the most severe spastic quadriplegia. And this translates across the lifetime. And I think over the past 5 to 10 years, there's been a lot more emphasis on the long-term survival. I think about these curves in comparison to what we see, for example, with our kids who survive with brain tumors. In some instances, the kids with brain tumors are doing much better than our kids with cerebral palsy and significant comorbidities. So we have a lot of room for improvement. If you think about the challenges we've had this spring when we have no visitors, and so you have, a 30-year-old in the hospital with significant severe cerebral palsy, as well as cognitive delay and who's nonverbal, that really dramatically impacts their survival, even if they are not suffering from COVID and just have a typical admission. So not all preterm babies are the same, and I think this again really impacts how we set up the clinical trials. This is from a study about family quality of life that recently performed in Israel, which has some similarities, at least from a neurosurgical perspective. I think they have some similarities as well in terms of their practice of neonatology. But they looked at family quality of life for kids with an average range of 5 years who have a shunt for posthemorrhagic hydrocephalus. And the factors, the neonatal risk factors in multivariate analysis that came through were neonatal seizures, as well as grade 4 or periventricular hemorrhagic infarction or cystic PBL. So those early signs really have an impact on the family, and we see this as we care for these families over the lifespan. And if you look at the later neurodevelopmental issues that these kids have, the number of neurosurgical operations has a huge impact, and I think this is because most of our shunt malfunctions happen anytime. especially it seems on holidays and other inconvenient times. So it has a significant impact on quality of life for the families. And obviously the poor cognition and the difficulties with social interaction that many of our kids have, and the added difficulties with severe cerebral palsy really make a difference. So, you know, we see the kids, the babies in the NICU with the severe IVH. Unfortunately, many of them self-resolve and don't turn into hydrocephalus. For those that do turn into hydrocephalus that requires early surgical treatment, those families are really destined for a rather challenging existence. And I think that sometimes it's hard for us to convey that adequately as we counsel them in the NICU. So we know that severe IVH increases the risk of deficits. If we look at just adding one side, losing both hemispheres to severe IVH, it increases the risk of cerebral palsy fourfold and increases their risk of significant cognitive delay threefold. So it's a real problem if they have bilateral severe IVH. And if you look at the kids that are shunted, 60% have moderate to severe cerebral palsy and 30% have epilepsy, compared to less than 5% who do not have a shunt. And I don't think that that's related directly to the scarring from the shunt. I think that our shunts, well, they carry away the excess cerebral spinal fluid that's not being absorbed. They also carry away trophic and supportive factors that may help circuit development. And again, just to reemphasize, this is a study from Europe where they looked at the impact of cognitive impairment on quality of life for people living with, for children living with cerebral palsy. And you can see in the top graph, it doesn't really matter how physically disabled the child is, they can still have a good quality of life if they do not have significant cognitive impairment. Whereas if you add in intellectual disability, even if they're physically doing fairly well, they have a much lower quality of life. So we really need to focus on cognition. And from my perspective, in the preclinical research realm, we've not focused on that perhaps enough. And I just want to put a little plug in here. I at least usually slightly different now with COVID, but as we're getting back into clinics, it's happening again, that at least once a week, a family with cerebral palsy will ask me about getting stem cells for their child. And I think that stem cells are going to be very effective. They're already very effective for some illnesses, but they're not there yet for our babies that are born preterm and don't really develop the brain in the first place. And then if you look at all the sort of difficulties that there are in the field, they may eventually, hopefully within the next few years, either stem cells or cell-based products will be helpful for our neonates. But I think it's quite a while before they're going to be useful for 5-year-olds or 10-year-olds, and especially when you think about a single injection and not really engineered cells. So it's a real problem. If you look at some of the basic research about this, this is neural stem cells given to 9-week-old mice. So these are kind of teenagers to young adults. And just varying the time of giving the stem cells after the stroke really changes the outcome that the animals can achieve. And so 3 days was the optimal time. But 6 hours or 24 hours right after the injury was not that as effective. And then delayed administration was not as effective. So if you think about our kids that go at, various ages after various types of injuries, there is really not going to be effective for them. And then I thought that these studies were very interesting as well. So you engineer new oligodendrocyte progenitors in a dish, and then implant those in the animals. And if you inject the cells in the frontal cortex, you can improve cognition, whereas it doesn't help motor skills, and vice versa. If you inject in the cerebellum, you can improve motor skills, but it doesn't impact cognition. So the idea that you would get a you donate your fat cells and then get an injection 24 hours later of really non-engineered cells into your bloodstream or your lumbar thecal space and have some impact, it really brings it into doubt. And I think this emphasizes the importance of the local microenvironment and the importance of development of these tracts. If you take embryonic motor cells and implant them in the motor cortex, they can develop nice pathways that have some degree of function. Whereas if you put those same cells that demonstrated a functional capacity into the visual cortex, they do not make connections. And vice versa, you can use visual cortex stem cells and improve visual pathways, but not impact the motor cortex and the motor pathways. So it's very important that as we approach things like stem cell treatment, that they be targeted and effective and very rigorously supported by extensive preclinical work. If we look at the current neonatal interventions we have, they're partially effective, and to me, they're very similar to our shunts. It's much, much better than having nothing to offer, but we still have some room for improvement. So our neonatal hypothermia is very helpful for about half of the babies that are born at term and have moderate injury. It still seems a little unclear about where to draw that distinction of mild injury where the babies are not treated. And unfortunately, the babies with severe HIE do not benefit as much. Similarly, for magnesium, it does seem to definitely help some babies if it's given appropriately before delivery. It may be less effective in the setting of chorioamnionitis. And again, we really need to develop better markers so that we can stratify the use of these treatments. If you think about the tremendous advances we've made in some of our really challenging brain tumors like medulloblastoma, we didn't get to that point until we could sort out and distinguish some of the other bad actors as tumors from the medulloblastomas and see which therapies were being effective. So that's why I think it's very important to stratify the clinical populations. There are some emerging trials trying to intervene earlier with early therapy programs, and I think it's very exciting to see those. We are trying to refer our families early and start the intervention programs in the NICU rather than waiting to start a few months after they've been discharged. And we're all very familiar with the BRIGHT trial and the PEANUT trials. The BRIGHT trial was a relatively smaller trial, is still multi-center, and they demonstrated some improvement with erythropoiesis stimulating agents, either EPO or DARBI, compared to placebo. The much larger and more rigorous PEANUT trial that just finished, it did not demonstrate such a significant difference. And there may be a lot of factors involved in this. I personally think it has to do with the stratification rate. So almost all babies under 28 weeks were able to enter the PEANUT trial, which is a great thing in terms of being inclusive. But I think that that lack of stratification made it challenging to detect a signal of improvement. And there may be factors that we can, or there's factors that we really can't anticipate in the preclinical work, such as they've recently proposed with iron deficiency anemia that existed in many of the babies that received the EPO. So how do we make tomorrow a little better? And I'm going to provide you a quick overview of some of our recent work. It is just going to be skipping across the surface and not very intense on the mechanisms. But I just wanted to give you more of a flavor of how we're thinking about trying to improve the neurorestoration. And I think about our babies in the NICU, they have a lot of insults, right? They may have had some pre-existing chorioamnionitis. They may have pre-existing sort of genetic vulnerabilities. They may have a challenging delivery and initial resuscitation. Then they have some neonatal challenges like sepsis, neck, bronchopulmonary dysplasia. They, there's many challenges that could really impact their cognition and their outcome, in addition to the direct brain insults like IVH and meningitis. So we're trying to think about that neurorestoration, not so much as a treatment that you would give just as a short course, similar to how hypothermia is used, but really longer to support the neurodevelopment. So our babies with preterm entry, as you all know, have significant white matter lesions, but they also have significant gray matter injury. This is different than what we see at term, primarily because the neurodevelopment is different, but it is there. They also have premature loss of the subplate, which has a significant impact on the circuit development. And I think there's just now emerging a real appreciation for how the early injuries impact the developmental maturation of the astrocyte lineages and the microglial lineages. And I think that will have a greater impact over the next 5 to 10 years as we learn more about that. So what we've tried to do in the lab is to understand the human problem better and use that to inform our preclinical models and really focus on highly translatable outcomes, then work on the mechanisms to really refine the therapies and get to better, more effective informed interventions. So while I was in Cleveland, I started working with erythropoietin, and I chose it in part because there was the emergent evidence that it might be effective, but also because it is used in the NICU for anemia. It seemed like it would be easier to translate. So EPO has a very storied history. This is Dr. Fisher, who, as a very junior attending, along with the med student, Mr. Birdwell, discovered that EPO was present in the kidney. So it re-emphasizes that you don't have to have many years behind your or through your career before you're able to make a significant discovery, and they really shouldn't underestimate what it takes. And then in the 70s, Miyake was a postdoc fellow, and he purified EPO from urine in working with his mentors, Kong and Goldwasser. He purified the EPO from the urine of the survivors of the atomic bombs, and used, over 2,500 gallons of urine. So when the members of our labs get frustrated with the sort of the tedious nature of some of our experiments, at least it's not that bad. In the 90s, it became evident that EPO signaling through the EPO receptor is very important in the brain, and there was a significant shift. And so there is a literature about sort of EPO and oxygen, but then there's also sort of a separate literature with studying it more as supportive of neurodevelopment over time, rather than just using it as a intervention shortly after the injury. And this work was really supported a lot by Tom Carmichael's work, where they were able to engineer a mouse that had EPO receptors deleted from the CNS, and they showed the importance of the EPO signaling during development. So you can see that the ganglionic eminences are missing in the developing mouse without EPO signaling, and then there's much less recovery after stroke if there's not EPO signaling present. So this was some of the work is sort of in the early 2000s that really supported the role of EPO in or using EPO for neurorestoration. So we developed this model, again, when I was in Cleveland, to better replicate injury from preterm birth. So this is an insult at E18, which is closer to around 24 weeks gestation in a human. So we initially started with a transient occlusion of the uterine arteries for different times and found we had graded injury. We decided to focus on repairing the severe injury because if my thinking at the time was if we can repair a severe injury, then it'll be easier to repair the mild injuries. And we demonstrated that there was significant dose effect, that we could get histologic improvement with a lower dose at a shorter course, but it really took a higher dose for a longer course to get functional improvement. That we did not see significant changes in the hematocrit. Obviously, more recently with the peanut trial, we have this in humans. It's no longer such a point that needs to be discussed. So EPO signaling in the developing brain is highly regulated. The EPO receptors are upregulated after injury. You can see here they're upregulated. I don't know if you can see my pointer, but they're upregulated here in the subplate. After the injury, the EPO signaling decreases about 100-fold postnatally. EPO receptors are expressed on most of the major neural cell lineages, including oligodendrocytes, neurons, astrocytes, and microglia. The receptor expression, again, is markedly upregulated after injury. If the cells are expressing a lot of EPO receptors and their EPO does not bind them, then cell death is triggered. And so it's very similar to what we see in the bone marrow. If there's not enough EPO around, when the cells need it, they die. And this happens for all stages of oligodendrocyte lineage, but particularly for the O4s, which are the cells that are most vulnerable to injury in preterm birth. So we used EPO in this model and demonstrated that we can repair gait. It turns out, from my perspective, I think gait is one of the easier things to repair. We used a computerized treadmill to analyze the gait, and we could show that, for example, they had markedly increased ataxia after the hypoxic ischemic injury at E18, and that we could normalize this with EPO. We also looked at diffusion tensor imaging and demonstrated that we can improve the microstructural abnormalities with EPO treatment, and this has been very consistent across different models over time. I like this model of the E18 injury because of the timing, but I wanted to add in inflammation because for 70% of spontaneous preterm births in the United States have chorioamnionitis present, and I felt that it was making a significant contribution to the later injuries or deficits that we see. So we added in the intraamniotic injection of lipopolysaccharide, which is a gram-negative endotoxin, and we color it with blue dye just so we can visualize it better during the injections. So the animals get a laparotomy on E18. They have an hour of hypoxia ischemia, and then we inject the lipopolysaccharide. And the sham animals have the same anesthesia and laparotomy and exposure of the fetuses, but they don't undergo the uterine artery occlusion or injection. And we demonstrated with this that we get gait deficits, whether we do the lipopolysaccharide alone or the hypoxia ischemia alone, but we get the most pronounced deficit if we use the combined injury. And so we've been using that now for several years as a model of preterm birth injury. And we added in melatonin, and I'll show you some of the data that inspired us to that. It, from an evolutionary standpoint, we evolved to have both of these agents support neurodevelopment. And so in that sense, it makes sense to combine them. In addition, they both have an excellent safety profile. So the pups undergo the injury, or sorry, the fetuses undergo the injury at E18. The pups are then born, and beginning on postnatal day 1, we start treating them. So this is equivalent to about the 3rd trimester. And we found that if we give a little longer treatment up to term, about P10, we have much better improvement. These are fairly high doses. And if you think about the mechanisms of EPO, EPO is very supportive of neural cell genesis, survival, and differentiation. Melatonin also does this as well, but perhaps not as vigorously. They both mitigate calpain degradation of important molecules during neurodevelopment. They both reduce neuroinflammation significantly. And melatonin in particular is perhaps better at limiting mitochondrial dysfunction and endoplasmic reticulum stress. And so together, I think that we can achieve better outcomes. And we've shown this with some of the deficits. So rats obviously have an evolutionary advantage, and they need a little stronger insult, and it's harder to bring out their deficits sometimes. So with the gait abnormalities, we can repair this with the combined treatment. We knew that we could get it also with EPO alone. We also were able to repair their social interaction, which is, I guess to me, is very reassuring, because for many of our kids, it's not their cognitive limitations that keep them from being employable, it's more their social interactions. So one area where EPO was not enough in isolation was looking at motor inhibition. So this is open field testing, and the rats that have the injury are a little bit hyperactive. They spend more time mobile, and the EPO treated rats were really no different than the vehicle treated rats. But when we added melatonin back in, we were able to normalize that. And similarly, when we look at their time immobile in the center, which a healthy rat does not like to be in the center in the light. And EPO really did not impact this, but when we added melatonin to the regimen, we were able to, again, normalize their activity level and their motor inhibition. So we then started to look at cognition and executive function. And so this is one of the areas, right, that our kids that are born preterm really struggle. They may be doing well initially, and then they come back to clinic for a routine follow-up, and they, failed the prior grade, which is very frustrating for the family. It's also frustrating that it wasn't anticipated and that they didn't have, appropriate educational accommodations in the first place, so they didn't have to go through the failure. If you look at our preterm survivors when they're teenagers, they do well if the testing is not too complex, but as soon as you start to challenge them with more complex tasks, especially related to executive function, they really start to fall off. They commit more errors. And so this testing is based on the Cambridge Neuropsych test automated battery called CANTAB. And we use a paradigm in the rats that's based on the same thing, so it's highly translatable. And so when these folks in their lab have used mutants with DLG2, which is fairly uncommon in humans, but it does exist, but they made a mouse to match, and then that they are tested in a human touchscreen paradigm, the curves match fairly nicely with what we see in the rodents. So it does suggest that if we can correct this in the rodents, then we may be able to correct it in the humans. So this is what they look like. These are, this testing is also performed in these touchscreen chambers that are sound and light adjusted. So they're not, like, for example, Morris water maze is very sensitive to environmental issues. And so these are not. There's also the data that comes out through the computer, and it's not impacted. So our undergrads can easily perform this, and we have reliable data all the time. It's a very nice system. So that here the rats learn how to receive the reward from the chamber in the back. They learn how to touch the screen, and then they learn how to distinguish between the different objects like the balloon and the spider. The objects we use, I should say, there's 12 objects and they've all been tested. So rats do not have an inherent desire to touch one object more than the other. And the objects are rotated around to decrease the bias. So first we test visual discrimination, whether they can accurately distinguish between the two objects, and they have to pass that. And then if they fail and choose the wrong response, they get a timeout and a correction trial to try again. Once they've passed visual discrimination, then we flip it up so that the correct answer is now incorrect, and we look at how long it takes them to accommodate that. And so this reversal is a test of cognitive flexibility, which is very important component of executive function. And so we were able to show that with the EPO melatonin treatment over approximately the third trimester equivalent, we were able to correct their cognition as adults. So this is a very durable improvement. We then used a different testing paradigm. First, we showed with visual discrimination that the rats in all three groups could perform the same. And then we used 5-choice. So 5-choice continuous performance test is a more challenging test, and it looks at the timing of your response and your attention. You also can have quantification if they have premature responses. So it's an idea, gives you an idea of how much control they have over their decision making. And again, this is used in humans. When we performed it, we found that the 5-second response time gave us the most informative information. So if they had 30 seconds to make a choice, they all got the answer right, whether they had injury or not. And similarly for 15 seconds, when it was down to 5 seconds, the injured rats that had vehicle performed poorly, whereas those treated with EPO and melatonin performed similar to shams. And then when we went to 1.5 seconds, it was too challenging for all of them. And so if we look at this, the sessions to pass at 5 seconds was much improved if they were treated with EPO and melatonin, and they had much fewer errors with the EPO melatonin treatment. They also had a lot fewer omissions and a lot fewer premature responses if they were treated with the EPO melatonin. So this suggests that we are able to modulate their cognition if they are treated in approximately the third trimester equivalent. They did not have any difference in their reaction time and magazine latency. So this is just controls showing that they all performed the same. They were all motivated to get their rewards. So we think about cerebral development. You're all familiar with the sort of developmental trajectory over childhood and the teenage years that we myelinate as teenagers. Executive function develops during that time. And interestingly, pain circuits also develop through childhood and begin in the third trimester. So they are vulnerable to the same types of injuries. And this is recently, chronic pain in people with cerebral palsy has recently come to the forefront. There was this workshop in Chicago that I was fortunate to attend a few years ago, looking at this. And it, for example, where I treat patients in clinic here at Johns Hopkins, our clinics are lifespan clinics. So we have adults that have chronic pain, and it's now become a huge research focus. And so we looked, if you look at teenagers, over half of them with cerebral palsy report chronic pain or pain that impacts their function. So we looked at our rats in this model of brain injury from preterm chorioamnionitis, and they also have a sort of predisposition to have a chronic pain phenotype as adults. So if we give them a painful stimulus, all of the rats react in the first 5 minutes to that painful stimulus. But then over the following hour, in these 5-minute bends from 2 to 12, the healthy rats in the shams in the gray bars sort of have a mild reaction, just like if you, hit something, you hit your finger in the car door, you have the initial pain, and then you whether it's endorphins or your blood pressure kicks up, but you settle down for a little bit, and then the real pain comes over the next hour or so. So that's what this is looking at, is sort of the cerebral perception of pain. And our animals that are treated with EPO and melatonin have a much lower pain profile. So if we look at the lift duration, it's significantly improved in our rats that have EPO and melatonin during third trimester. And to me, this is extremely important because it suggests that if we can do early interventions in neonates or infants, perhaps we can prevent this significant chronic pain in adults with cerebral palsy. It's the leading cause of people with cerebral palsy leaving the workforce as adults. And so now I'm going to shift to posthemorrhagic hydrocephalus of prematurity and our work in that area. Again, we want to go from the models to translatable outcomes to find better interventions. And so this is a poster from the Hydrocephalus Association a few years ago. Hydrocephalus really impacts families tremendously. This is the big sister of the little boy that's being held there by his father because he has CP as well as his son. And this is from a walk we had here in Baltimore. And as you would have it, I have 3 partners here, and one of us had to go in to fix a shunt during the hydrocephalus walk on this beautiful Saturday morning. So this anxiety of the shunts malfunctioning at any time is very stressful for our families. So I replaced the walk to end hydrocephalus to an emphatic run. And so to start working on this is some work that I started once we moved here to Hopkins. We started looking at what factors caused IVH to convert into posthemorrhagic hydrocephalus that would need treatment. And so there's a well-established literature from around the world that intrauterine infection contributes to IVH. And this is some more recent work that just came out a couple months ago, that racial segregation in the United States can contribute to intraventricular hemorrhage. So most of us are aware that there's significant socioeconomic impact on how our preterm infants do. And this study, they were able to show that Black infants from an area of significant racial segregation are much more likely to have IVH. I think this has a tremendous importance for trying to approach how to reduce the incidence of IVH, at least here in the United States. Well, I was at Rainbow Babies. We looked at the babies in the NICU. So we took the NICU database and looked at all the babies with severe IVH, and then looked at who needed to be shunted and why, or what other comorbidities they had. And it turns out there was a significant association with sepsis. So our babies with severe IVH who had sepsis were much more likely to need surgical intervention. And this relationship between sepsis and the need for shunt after intraventricular hemorrhage sort of is sustained across the lifespan. So this is from adults with subarachnoid hemorrhage. And if they had Sears or a sepsis-like picture, they were much more likely to require a shunt after several weeks of external drainage. If we look back at the ultrasounds, we can see that when our babies in the NICU have their initial hemorrhage, there's not much ependymal inflammation detected. And then by a few weeks later, there's a significant ependymal echogenicity there that extends into the temporal horns, for example, where there's not really typically direct clot. If we look under the microscope, what's involved here, both in your preclinical models as well as in postmortem samples, you can see areas of gliosis and loss of ependymal cilia. And it turns out that there's, in the past several years, it's been demonstrated the importance of motile cilia on the ependymal wall. So the ependyma produce these cilia, and during development, so in the rodent, it's during the first 3 weeks, in the human, it's over the first 6 months, beginning in the 3rd trimester and then to 6 months corrected, there's maturation of these cilia, and they have to form in the first place, but then they localize on the cell surface to develop into a tuft that can propel. And so in this really elegant zebrafish study, they were able to, isolate the factors. So you can stop the heartbeat in a zebrafish. We don't do that typically in our mammals. But they were able to demonstrate that you need to have a heartbeat, you need to have some body movement, but really the motile cilia, if they eliminated those, there was no CSF flow. And this is looking across different animals. Some argue that the cilia may be important in, for example, zebrafish, but not really important in the larger mammals, where sort of the size makes a difference. But this was an elegant study from a few years ago now. These are flow-directed maps of fluorescent beads in mice and rats and pigs that demonstrate that there's significant flow generated by the motile cilia. And this is a really interesting study, again, from a few years ago. So lysophosphatidic acid is a blood-borne molecule that's present in the setting of sepsis. And so they injected LPA into the ventricles of mice in utero, and then postnatally they developed this hydrocephalus. You can see the nice domed head, and then they measured the intraoral distance, which is a rodent version of the head circumference. And they noted that there was loss of the motile cilia, and then to further demonstrate this, there were additional studies that showed that if you inject the LPA, it causes loss of the transcription factor, YAP. And then they made a conditional knockout of YAP in the brain, which those animals developed hydrocephalus, and then they could inject YAP and rescue the cilia. So it demonstrated that YAP is important and related to the LPA induced hydrocephalus. And it turns out that YAP is actually the transcription factor that drives radioglia to become ependymal cells. So if infection is present, then there's probably lower levels of YAP, which then impairs cilia development. So we again took this to our rodents and developed a new model of posthemorrhagic hydrocephalus. Our rats have chorioamnionitis on embryonic day 18, and then they get IVH. We take a littermate's blood and make a lysed red blood cell prep and inject that intraventricularly into each lateral ventricle on postnatal day 1. And then some of them are treated with EPO and melatonin, and we assess them. We initially assessed them out to P21, and now we go through to adulthood. But they developed a domed head. They have a larger intraoral distance, whereas if they get the chorioamnionitis alone, or if they get IVH alone, they don't develop the enlarged heads with the macrocephaly. They have significant ventriculomegaly. So, the chorioamnionitis alone rats sometimes have some mild ventriculomegaly, but they do not develop the enlarging heads suggestive of symptomatic hydrocephalus, whereas our animals that get the combined injury do. They have a larger ventricular volume at P5 and then at P21, measured on MRI. We did neonatal neurodevelopment in the rats, and they had impaired cliff inversion. Our Animals with chorioamnionitis alone also had impaired cliff aversion. We did not find significant differences between the sexes. They're both susceptible to the injury. And so this model has progressive macrocephaly, sustained ventriculomegaly, and neurodevelopmental delay. And so we use that to test whether EPO and melatonin, if given early, could prevent the onset of the hydrocephalus. And we were able to show that we were able to prevent the macrocephaly. You can see the vehicle-treated rat at P16 has a nice domed head, whereas the animal treated with EPO melatonin has a normal cranial shape. And we did some studies to demonstrate that it required both a combination of EPO and melatonin, and that one agent alone was insufficient. We were also able to repair their deficit in cliff aversion, and this is demonstrating that we could improve the ventricular volume. It was not completely normalized with this regimen. We did make a significant improvement in the DTI metrics. So you can see that the injured animals with vehicle, the colors are not in the directional color maps, the colors are not as bright and sharp. There's less signal in the corpus callosum and some of the other areas of white matter. And this is just demonstrating that we were able to repair the fractional anisotropy in multiple areas. We also were able to improve the mean diffusivity and the radial diffusivity as well. And so we looked with scanning electron microscopy at the cilia. We found that the cilia in the shams forms these nice tufts, whereas the cilia in the injured rats with many areas that was missing in the where it was present, they were kind of bloated and not in a nice tuft. But if they were treated with EPO and melatonin, they again had the nice tough shape. So we wanted to look more at the mechanisms for this, and so we developed this pipeline. So we ensure the phenotype, and then we take the lateral ventricular wall with the ependyma. We put fluorescent beads on that and perform video microscopy, and then use software with Amaris to analyze the bead flow. And then we could take those same preps and then do sophisticated immunohistochemistry or biochemistry analyses there. And so we looked at the bead flow in the normal animals initially and demonstrated that there's maturation. And then with the injured animals, they have a slower bead speed, and then their flow is not as directed. So in the lower chart, it shows that the sort of the angle of the flow is much more diffuse in the injured animals. And here's the demonstrating during development, the bead speed is normalized with the EPO melatonin treatment, as well as sort of the straightness, and the flow is much more directed if they're treated. And if we go back and look at these, some very elegant work by Joanne Conover in her lab on human ventricular wall development compared to rodents, they have a similar pattern. Again, you can see on the left, the 28 gestation week human has a lot of immature ependymal cells as well as radial glia. So this is a typical age, right, for our baby to have the IVH. And then as they get closer to term, there's more mature ependymal cells, but they still, are still struggling at 6 months. And this may be related to why our shunts don't do so well until after 6 months. So again, that concept that age matters. The immune system is undergoing the same sort of development. So choroid plexus macrophages also have different populations. And then, as I mentioned before, the ventricular volume was not completely corrected. So we extended the EPO melatonin treatment out through infancy to P20. And we were able to achieve much better improvement in the ventriculomegaly. And so we are proposing to treat the babies with EPO and melatonin with a longer course than was used in the peanut trial. Another thing we are doing is trying to see if we can treat later. So like if we begin treating at P15 more like infancy, or even P20 into as toddlers, are we able to repair their gait and their cognition and their pain phenotype? So we're working on those now. So in conclusion, I think sustained interventions are important. We have to think about the development of the different lineages we're trying to repair, and most efficacious interventions are likely going to need sustained treatment over time. Combination will probably be better to accommodate the various differences we have in humans. And we need to think about the timing of the dosing, the duration, and the amount that we are giving over time. And that may, obviously, if we have biomarkers to stratify, that would be better. So we want to clarify the windows for when we can give interventions. If we could give, EPO melatonin to 5-year-olds and improve their gait with a intensive rehab course, that would be excellent. We're going to look at trying to bring the EPO melatonin to our babies with IVH to see if it's safe, and then continue to look for additional molecules to add to the cocktails. So I want to thank everyone. This has been a huge amount of work, and primarily my long-term collaborator, Lauren Jancy, is a developmental neuroscientist, and she has her own lab, but we collaborate on a lot of projects, especially related to the hydrocephalus and the repair of cerebral palsy. And I'm immensely indebted to Francis and the entire team here in the neonatal, the neurosciences intensive care nursery. It's a very stimulating environment. So I'll be happy to take any questions, and thank you very much.
Thank you so much, Dr. Robinson. I think it's a fascinating research. I'm sure there are some fortunate babies who are going to be benefited with this research, the benefits of this research. There are a few questions I see here. I think this is related to the first part. Where do we get these stem cells from? This is from the cord blood bank.
I'm sorry, I couldn't hear.
The initial part of your presentation, I think they asked about where do we get these stem cells from?
Oh, so I think so stem cells, there's a couple options. So like if you could take mesenchymal stem cells are very good candidates. You could use umbilical cord cells from the baby if they're stored, but if they're not stored, there's ways now that you could take, for example, if you wanted to treat an infant at a year-old, you could take their own cells and then re-engineer them over about 6 to 8 weeks and then give them back. So that is an option. The problem with taking umbilical cord cells, say from, a 25-weeker, is they were probably born at 25 weeks in most cases for reasons that the intrauterine environment was not healthy. And so their stem cells may not be healthy. So it may not be best to give them back sort of their own immune system that's already been injured. There's a lot of challenges.
The other question is, any side effects with the combination of the EPO and the melatonin?
So we have not seen any side effects in the rodents. There's an obvious issue if you think about the melatonin potentially with the sleep cycle, but in general, it should, what we're seeing in the preclinical work is this very similar to what we see with the EPO, is that the inflammation decreases the signaling through the melatonin receptors. So if we supplement it, we should normalize the situation. Both EPO and melatonin pathways downstream are regulated by other systems, so they're unlikely to sort of get out of control by giving supplements. So we're basically trying to replace a deficit. It's very different than inhibiting, say, you give an antagonist or inhibitor, that obviously may have significant side effects that we didn't anticipate. And that's where both EPO and melatonin are regulated, and we're replacing deficits that exist because of the neuroinflammation.
Thank you. And then the form of melatonin, like is this oral form or intravenous form which you used?
So for the trial that we have proposed, we haven't started yet, we've proposed using oral. There are some IV formulations that are being developed in Europe, but there's no FDA approved IV formulation in the US. And I did not want to start out trying to get, use that IV formulation first in the NICU. That just seemed like a significant challenge. So we're going with the oral to try.
I have a question. So from the time EPO was tried in animal studies and then came into the clinical practice, clinical use, what do you think this melatonin, like for a large scale use, what do you think the timeline will be? Okay.
I'm hoping actually that it might be short. So there's some labs that are looking at melatonin alone. There have been studies in humans using 10 times the dose that we're proposing, and it's been safe. So I'm hopeful that there won't be significant side effects and that it'll be well tolerated. So I'm hopeful it'll be fairly soon that we can translate.
One more question. What outcome measures you will be using for human clinical trials?
So for the posthemorrhagic hydrocephalus, it fortunately has a reasonable parameter in that if we give the EPO and melatonin to babies who have severe IVH, we have a fairly good idea how many will become symptomatic and require either temporary procedure or permanent procedure like a shunt. And so we can use that fairly short outcome to see if it's potentially beneficial. We have to show, of course, that it's safe first, but you could conceive that babies with severe IVH could start treatment and see if we can prevent them converting over to needing a shunt or other surgery.
I think from your earlier studies, like earlier presentation, so I see the motor and the cognitive, both are predominantly. Do you think a role for vision and the language areas also to be improving with this?
I think it should be important, right? So there's a lot of work about the subplate in the visual cortex and the development through adolescence with the critical periods and things. So I think that they, motor's been a focus partly because we see it's easier to see the kids with CP, right? Unless you really ask about cortical visual impairment, it's not the thing that the parents bring the kid into clinic for. I think many of our kids, are undiagnosed and undertreated for that. But I think that all the mechanisms and the work that we see, it suggests that we should have the same improvement.
Thank you. And there are a couple more questions. What dosage of melatonin probably will be proposing in the trial?
We're proposing 20 milligrams per kilogram.
Then what grade of, what IVH grade are you suggesting to use this melatonin? Or can it be used prophylactically?
So we're suggesting using it in grade 3 and grade 4. I mean, I realize that the kids with grade 1 and grade 2 are also risk of deficits, but they're, from my perspective as a neurosurgeon, we really need to work on the hydrocephalus first. And it's easier to, most people agree about the definition of a grade 3 and a grade 4. When you start to go to grade 2, sometimes the radiologists are not consistent. It's also, you would have to test a lot more kids to get an answer.
And then regarding the infection, you mentioned about choreo. What about early onset sepsis, like early onset, the GBS or the gram-negative sepsis in these babies?
I think that contributes. So there's there's a Hydrocephalus clinical research network, and they're currently collecting data about which babies need shunts and whether they had sepsis as part of that. So I think it contributes. We did that study at Rainbow where we looked over about a 12, 14-year period, and there was a strong association. So I think, I mean, that was obviously limited because it's a single center study, and I'm not sure the definitions of sepsis have been the same over those decades and things. So I think a current study would be better, but I think there's a strong association there. I think that the EPO and melatonin may also be beneficial for meningitis-induced hydrocephalus, and we're looking at post-infectious hydrocephalus in the lab right now, see if it's effective or not.
Thank you so much. Let me see if we have any more questions. All right. Thank you, Dr. Robinson. Thank you so much. And we are looking forward to the fruits of this research in the practice.
Well, thanks so much for having me.
Thank you. And you have a great day. And,
thank you. Take care.
Next weekend. And thank you all who have joined this lecture. Thank you so much for taking your valuable time. And I wish you all a nice weekend.